Hello, my name is Robin Ray. I'm a consultant cardiologist at St George's Hospital in London. I thank the ESC Working Group on Cardiovascular Pharmacotherapy for asking me to give this talk on optimizing heart failure therapy following myocardial infarction. So the learning objectives are firstly to describe the optimization of pharmacological therapy for chronic heart failure as per the ESC guidelines, and this is what I'll focus on in this presentation. Secondly, to understand the role of device therapies in heart failure management. And lastly, assessment and managing comorbidities seen in heart failure. So I'd like to introduce you to Mrs. Patel. She has a background of hypertension, diabetes and obesity. Both the hypertension and diabetes were historically quite poorly controlled, in part due to poor compliance with medication. And she started to develop breathlessness over a period of 6 months and had 2 admissions to the accident and emergency department. These were treated as chest infections. She then presented with sudden onset shortness of breath and chest tightness. An ambulance was called, although not immediately. An ECG demonstrated ST elevation, and she was taken to the nearest primary PCI service. Now, her past medical history consisted of mild vascular dementia, obesity, osteoarthritis, osteoporosis, and a recent neck of femur fracture. Her medication are listed here: aspirin, irbesartan, pravastatin, gliclazide, and ibuprofen. Now, you'll note from the ECG, this demonstrates significant ST elevation in the anterolateral leads. There were Q waves evident already as well. And initially she needed some oxygen and IV furosemide due to breathlessness, but went straight to the cath lab for coronary angiography, which demonstrated a proximal LAD occlusion with diffuse disease in the other arteries. She went on to have PCI to the LAD with a drug-eluting stent and a call to balloon time of about 140 minutes. Now, following on from PCI to the LAD, she went on to have a chest X-ray, which you can see shows cardiomegaly and pulmonary congestion. And also an echocardiogram which confirms severe left ventricular impairment with ejection fraction of about 25 to 30% and a mildly dilated ventricle with mild left ventricular hypertrophy and mild mitral regurgitation. It's important to recognise that left ventricular dysfunction is the single strongest predictor of mortality following STEMI. There are a variety of mechanisms responsible in the acute phase, including myocardial loss and remodeling due to infarction, although there may be some ischemic dysfunction or stunning and complications of atrial and ventricular arrhythmias and valvular dysfunction, although this lady only had mild mitral regurgitation. So what are the management goals for this patient? Firstly, we want to optimise heart failure therapy and reduce cardiovascular events. Secondly, reduce the risk of sudden cardiac death. And lastly, as per the latest ESC guidelines, use a holistic approach and focus on managing the comorbidities which may exacerbate heart failure. So, following the primary PCI, she went to the ward and was noted to have clinical evidence of fluid overload and was managed with oxygen and CPAP and IV furosemide to good effect. Following stabilisation, her pulse was 90, blood pressure 140 by 88. Now, you'll note plasma NT-proBNP was significantly elevated at over 5,000, and it's well known that NT-proBNP levels correlate with prognosis in patients with acute and chronic heart failure. In a subgroup of the Copernicus study, the median baseline NT-proBNP concentration was just over 1,700, and all-cause mortality at 1 year was significantly higher at 22% for patients with plasma NT-proBNP levels above the median compared to those below the median, where it was only 7%. Now, all patients undergoing primary PCI should ideally receive either ticagrelor or prasugrel as early as possible after the diagnosis of STEMI has been made. Clopidogrel can be used if the others are not available. These 2 agents cause more intense platelet inhibition than clopidogrel, and randomized trials have found improved outcomes with their uses. This is a Class 1A indication. Now, ticagrelor was compared to clopidogrel in over 18,000 acute coronary syndrome patients in the Plato trial, 38% of whom had STEMI with intended PCI. Patients were randomly assigned to ticagrelor 180 milligrams loading dose, followed by 90 milligrams BED, and were noted to have a lower primary endpoint, which was a composite of myocardial infarction, stroke or cardiovascular death of 9.4% compared to 10.8% in the control group. The combination of aspirin and a P2Y12 receptor blocker should be continued for at least 12 months, unless there has been significant bleeding episode or if the background risk of bleeding is very high. So on day one, our patient was actually much better. Blood pressure was 160/88, pulse was 96 beats and regular. She was on aspirin and ticagrelor, and omeprazole was added for gastric protection. This is appropriate for patients with multiple risk factors for bleeding, such as advanced age, concurrent use of anticoagulants and non-steroidals, although in this case her ibuprofen was stopped. Pravastatin was replaced with atorvastatin. High-intensity therapy is recommended in all patients with acute myocardial infarction, irrespective of cholesterol concentration at presentation, and should be started as early as possible. This is associated with early and sustained clinical benefits. Statin therapy can reduce 5-year incidence of major coronary events, coronary revascularization and stroke by about 1/5 for every millimole reduction in LDL cholesterol, largely irrespective of the initial lipid profile. Ramipril was also started in place of irbesartan, and intravenous furosemide continued. Now, ACE inhibitors are recommended in patients with reduced left ventricular ejection fraction, that's to say less than 40%, who've experienced heart failure in the early phase. This is a class 1A indication, and if not tolerated, an ARB such as valsartan can be considered, with evidence from the Valiant trial. Although I'm also quite fond of candesartan in view of the CHARM trial data that's applicable in chronic heart failure. A systematic overview of ACE inhibition early in STEMI patients has indicated that therapy is safe, well tolerated, and associated with a small but significant reduction in 30-day mortality, with most of the benefit observed in the early phase. Most randomized trials have demonstrated that a variety of ACE inhibitors started as early as 24 hours up to 2 weeks following an acute myocardial infarction improves left ventricular ejection fraction at 1 month up to 1 year. The mortality benefits are greater in those such as Mrs. Patel with lower ejection fraction, clinical heart failure and also anterior myocardial infarction, with approximately 50 lives saved for every 1,000 patients treated. ACE inhibitor therapy should be titrated to the highest tolerated doses used in clinical trials. There have been a number of trials that have tried to address whether low compared to high or standard doses of ACE inhibitors and looking at clinical outcomes. The largest trial was ATLAS, and this compared low with high dose lisinopril and suggested that there may be a decrease in morbidity but not mortality with higher doses. The trial randomly assigned just over, 3,000 patients to either low or high dose lisinopril and compared the low dose regime with the high dose. The high dose was associated with a non-significant 8% reduction in mortality. However, the high dose significantly lowered the combined endpoint of mortality and hospitalization for any cause by 12% and heart failure hospitalizations by 24%. These benefits of high-dose lisinopril were also seen in high-risk patients, including those with diabetes, hypertension, hyponatremia, renal dysfunction, and also elderly patients. This is a Lancet meta-analysis evaluating 5 heart failure trials, 3 starting during the first 1 to 3 weeks post-MI. So that's the top right graph, SAVE, AIR, and TRACE trials. But altogether involving just over 12,000 patients with an average follow-up of 35 months, with left ventricular ejection fraction less than 35%, or less than 40% if there was also clinical heart failure. ACE inhibition was associated with a lower total mortality, 23% versus 27% compared to placebo. Most of the mortality benefit was due to fewer deaths from progressive heart failure. The benefit of treatment was apparent quite soon after the start of treatment, and you'll note there was also continuing divergence in the mortality curves during the follow-up that exceeds 4 years. There was a lower rate of a readmission of heart failure, so 14% compared to 19%. There was a lower incidence of myocardial infarction, 9% versus 11%, but no difference in stroke. Overall, there was a significant reduction in death, myocardial infarction, and heart failure hospitalization. And this translates into 7 patients with at least one event prevented for every 100 patients treated. So moving on, the evidence for early use of beta blocker therapy in acute myocardial infarction, again, is historic and predates primary PCI in the era where no reperfusion therapy was available. A number of randomized trials in patients treated with propranolol, metoprolol and atenolol have demonstrated a reduction in cardiovascular mortality of approximately 20%. These patients did not routinely receive statin therapy or P2Y12 receptor blocker therapy, both of which now are standard of care. We know that beta blocker therapy reduces infarct size and early mortality when started early, and also lowers the risk of death when continued long term. Reducing oxygen demand through reductions in heart rates, which also improves coronary artery perfusion pressure. Reducing arrhythmia through reduced automaticity. Now, I've put 2 beta blocker studies here, more contemporary. The first is effect of metoprolol in cardioprotection during an acute myocardial infarction. This involved a very early administration of IV metoprolol followed by oral metoprolol at a time of diagnosis in patients with anterior STEMI. And this was associated with firstly a reduction in infarct size measured by cardiac MRI at 1 week, and secondly by a higher left ventricular ejection fraction at 6 months, again measured by cardiac MRI. There was also a significant reduction in the composite of death, heart failure, admission, reinfarction or malignant ventricular arrhythmias at 2 years, 11% in the beta blocker group, 18% in the placebo group, and a significant reduction in the incidence and extent of microvascular obstruction on cardiac MRI. In the early BAMI trial, this was a larger trial in STEMI patients, this showed no significant benefit with beta blockers and no significant difference in infarct size. I think it remains inconclusive as to whether beta blocker use beyond 1 year truly reduces mortality in the current era of acute myocardial infarction and post-acute myocardial infarction care, particularly in patients with preserved left ventricular function. In these and other low-risk patients, so young, no arrhythmias, no residual ischemia, prolonged use of beta blocker therapy appears to be, I think, unlikely to confer significant mortality benefit. So this is, of course, in contrast to beta blocker trials in patients with heart failure and reduced ejection fraction, like in our case study, which have demonstrated reductions in mortality, hospitalization rates, and symptoms. A number of major trials have demonstrated a survival benefit with several beta blockers, sustained release metoprolol, carvedilol, bisoprolol in selected patients with heart failure. This is a class 1A indication for beta blocker therapy long term. One interesting question is whether patients with heart failure and reduced ejection fraction and atrial fibrillation benefit in a similar way with beta blocker therapy, as a recent meta-analysis a few years ago showed that all of the major beta blocker trials in heart failure with reduced ejection fraction had no benefit on hospital admissions and mortality in the subgroup of patients with heart failure with reduced ejection fraction and atrial fibrillation. So this is a systematic review, a network meta-analysis of the efficacy of different beta blockers in heart failure in 21 randomized controlled trials focusing on atenolol, bisoprolol, carvedilol, metoprolol and nebivolol. As expected, in the overall analysis, beta blocker therapy provided credible mortality benefits in comparison with placebo or standard treatment after a median of 12 months of follow-up. However, there were no differences when comparing the different beta blockers head-to-head for the risk of death, sudden cardiac death, death due to pump failure, drug discontinuation, and improvements in left ventricular ejection fraction were also similar, irrespective of the individual study drug. This data suggests that the benefits of beta blockers in patients with heart failure and reduced ejection fraction seem to be mainly a class effect. So going back to our case study, regarding medication, ramipril was increased to 2.5 milligrams twice daily and a small dose of bisoprolol added. The furosemide was converted to an oral preparation. Now moving on, this is the algorithm that I'm sure you'll be familiar with for patients presenting with symptomatic heart failure and reduced ejection fraction. It is a class 1A recommendation for ACE inhibitors and beta blockers, but if still symptomatic, a mineralocorticoid receptor antagonist, an MRA, should be added, again a class 1A indication. We have a choice of two MRAs currently, spirolactone and eplerenone. The efficacy and safety profile of spirolactone was assessed in the RALS trial, which investigated patients who actually were quite symptomatic in NYJ class 3 and 4 with left ventricular ejection fraction less than 35%. The mean in the trial was 25%. Patients were randomly assigned to placebo or a single dose of spirolactone, 25 milligrams, sometimes increased to 50 milligrams, and excluded if the creatinine was greater than 221 or serum potassium greater than 5 millimoles per litre. After an average follow-up of 2 years, the study was stopped because there was a significant 30% reduction in overall mortality with spirolactone. So you'll see 35% versus 46% for placebo, and a 35% reduction in hospitalisation for heart failure. You'll note that the benefit of spirolactone was evident early on at 3 months, and this persisted for the 2-year duration of the study. It must be noted, though, it's quite difficult, I think, to compare trials, as at the time of the RALS trial, use of beta blocker therapy was limited. However, the benefits of MRA with concomitant beta blockers has now been established with subsequent randomized controlled trials. The efficacy of eplerenone in patients with less symptomatic heart failure was demonstrated in the EMPhASIS HF trial. This study enrolled just over 2,700 patients in NYJ class 2 heart failure, and either a left ventricular ejection fraction less than 30% or ejection fraction between 30 and 35% if the QRS duration was greater than 130 milliseconds. The mean left ventricular ejection fraction was similar again, 26%, but it must be noted that I think only 96 patients were enrolled on the basis of the QRS duration and ejection fraction between 30 and 35%, so the majority had left ventricular ejection fractions less than 30%. The patients had been hospitalised for a cardiovascular reason, approximately half for heart failure within 6 months, or had a BNP greater than 250, an NT-proBNP greater than 500 in men, 750 in women. Now, unlike RALS, most study subjects were receiving ACE inhibitor or ARB, as well as beta blocker therapy. Although similar to RALS, patients with potassium greater than 5, eGFR less than 30 were excluded. Eplerenone was given at 25 milligrams per day, and this was increased at 4 weeks to 50 milligrams per day if renal function and potassium levels allowed. There were some variants, so in those with slightly poorer renal function, so an eGFR between 30 and 49, patients were tried on eplerenone 25 milligrams on alternate days initially, and then up titrated if possible. Now, at just under 2 years, the study was stopped prematurely, and this was because eplerenone significantly lowered the rate of the primary outcome of death from cardiovascular causes or heart failure hospitalisation by 37%. You can see 18% versus 26% in the placebo group. Eplerenone also significantly lowered mortality rate by 24%. This was 12.5% for eplerenone, 15.5% in the placebo group. And there's also a lower rate of death from cardiovascular causes. There was a 42% reduction in heart failure hospitalisation with eplerenone, and this is greater than that seen in RALS, despite this being a less symptomatic population. So pertinent to our case presentation is another trial involving eplerenone, specifically in post-myocardial infarction patients. In the EPHASIS trial, patients who had a myocardial infarction 3 to 14 days previously with an ejection fraction less than 40%. The mean in this cohort was 33%, so slightly higher, with evidence of heart failure and or diabetes mellitus. Most patients in Ephesus were also receiving treatment with an ACE inhibitor or ARB, about 87%, and a beta blocker, about 75%. Patients were excluded again if the creatinine was greater than 221 or a serum potassium greater than 5 millimoles per litre, or were taking potassium sparing diuretics. Over 6,000 patients were randomly assigned to either placebo or a pleuronone, 25 milligrams for 4 weeks, and then increased to 50 if, again, potassium levels and renal function allowed. And a follow-up of 16 months, in the top graph you will note, a pleuronone had a significant 15% lower rate of all-cause mortality, so 14.4 versus 17% in placebo. And this was entirely due to a reduction in cardiovascular mortality, 12% versus 15%. Pleuronone was also associated with a 21% reduction in sudden cardiac death, which accounted for approximately 1/2 of the mortality benefit and hospitalizations for heart failure. Again, very early mortality benefit with a pleuronone, which was significant by 30 days following randomization. Now, both spironolactone and the pleuronone are recommended in all symptomatic patients already treated with an ACE inhibitor and a beta blocker and ejection fraction less than 35% to reduce mortality and heart failure hospitalization. Both block aldosterone receptors but have different degrees of affinity for other steroid hormone receptors. For this reason, a pleuronone is associated with fewer endocrine side effects, and this can be 10 times less, such as gynecomastia or breast tenderness, than spironolactone. So this was 1% in Ephesus with a pleuronone, and gynecomastia was 10% in the RALS trial with spironolactone. So it's often my drug of choice in younger men, particularly in view of the side effect profile and also to improve compliance. A pleuronone does not affect any metabolic parameters, glucose, cortisol, while spironolactone is associated with increased plasma HbA1c and cortisol levels in patients with chronic heart failure. Increased HbA1c levels with spironolactone treatment relative to placebo has also been observed in patients with diabetes. Based on these results, it appears that a pleuronone may be the MRA of choice in patients with diabetes, and probably in those with visceral obesity and the metabolic syndrome who are developing or at risk of developing diabetes. There are differences between spironolactone and a pleuronone in their pharmacokinetic properties. You'll note that spironolactone has a complex metabolism and a long half-life of 12 hours in healthy individuals, and this actually extends to 24 hours in those with heart failure, as it's converted to 2 active metabolites in the liver. A pleuronone, on the other hand, does not have these active metabolites and a much shorter half-life of 3 to 4 hours. Now, the guidelines do give advice on how to manage MRAs in patients with renal impairment or hyperkalemia, as you will note in this box at the bottom, taken from the guidelines. RASI-induced hyperkalemia often limits the use of these drugs, thereby potentially offsetting the survival benefits. The RALS investigators actually did a dose-finding study to assess rates of hyperkalemia with spironolactone, and they noted increasing kind of dose-dependent increases in hyperkalemia with an increasing dose of spironolactone. So it was about 5% with the 12.5 milligram dose, 13% with the 25 milligram dose, rising to 20% with the higher dose of 50 milligrams. And for that reason, I think spironolactone 25 milligrams was chosen as the ideal dose in the RALS trial. If you look at a different cohort, so in hypertensive patients without risk factors for hyperkalemia, the incidence of hyperkalemia with RASI monotherapy is less than 2%, and this increases to 5% with dual RAS inhibition and to 5 to 10% if dual therapy is given to patients with either heart failure or chronic kidney disease, and obviously even higher if they have both of these conditions. If you look at the trials that I've mentioned, in the RALS trial, there was an overall increase in potassium levels by 0.3 millimoles per litre, and serious hyperkalemia, that's greater than 6 millimoles per litre, occurred in 2% of the group treated with spironolactone. In Ephesus, the rates of hyperkalemia were 5.5%, although this was higher. An equivalent dose of, there was a slightly higher equivalent dose of eplerenone, and more patients were given beta blocker treatment, which also increases the risk of hyperkalemia. In view of the longer half-life of spironolactone, it theoretically has a greater chance of causing hyperkalemia. However, it's very difficult, I think, to compare spironolactone with eplerenone without a direct comparator trial, although the available evidence does suggest that the risk of hyperkalemia is lower with eplerenone. It's important to show caution in patients with significant renal dysfunction, particularly those with an eGFR less than 30. And it may be that we have to consider the use of new potassium binders, including patiromer or ZS9, to enable optimization of heart failure therapy. We'll see what this shows, but trials are underway to potentially look at this. The greatest change in potassium is usually in the first 4 weeks following MRI initiation. And this finding is really important because what we must do is really measure potassium levels quite closely in the initial phase, so probably about a week after starting eplerenone and at least 4 weeks after as well. So moving on, this is the case. So on day 3, as per Ephesus, eplerenone was added into her therapy, the furosemide was stopped, and the ramipril dose doubled as the blood pressure and renal function and potassium levels were stable. She had ended up having an inpatient stay of 10 days, which is the average for patients presenting with heart failure in our institution. Although for her, this was delayed due to social circumstances. But I have to say, this gave us the opportunity to up-titrate her medication according to evidence-based therapy. And what the European guidelines suggest, as you can see in this table on the right, except for bisoprolol, which went up to only 5 milligrams once daily, limited by her heart rate. She was then discharged with follow-up with the community heart failure nurse at 2 weeks, the cardiac rehabilitation team, and also a cardiologist at 4 weeks. So unfortunately, she did not turn up to initial appointments as she went for a long holiday to visit her relatives abroad, but she did come back and was reviewed 4 months later. This was clearly not ideal, as studies have shown that early follow-up of patients with heart failure reduces hospitalization rates. Although in her case, because of her slightly prolonged inpatient stay, she was optimized prior to discharge. She was clearly better, although was in NYJ class 2 to 3 category with mild fluid overload. Blood pressure, pulse, potassium levels, and renal function were all satisfactory. And her NT-proBNP level had come down, but as you can see was still raised at 1300. Her eplerenone was increased to 50 milligrams once daily, and she was counselled and referred for a primary prevention ICD as her left ventricular ejection fraction remained poor on repeat echocardiogram. The guidelines confirmed that a primary prevention ICD in this setting is a class 1A indication in symptomatic patients with left ventricular ejection fraction less than 35% who have been on optimal medical treatment for greater than 3 months. Now, a number of randomized clinical trials have established a clear role for the primary prevention ICD in selected patients. These include MADE-1, MADE-2, and the MUST trials. The risk of sudden cardiac death increases with the severity of both left ventricular systolic impairment and the degree of clinical heart failure. Patients should be at least 40 days post-MI and more than 3 months following revascularization and taking guideline-directed medical therapy. There are, of course, particular patients who may require a defibrillator at an earlier stage, depending on assessment of their risk. Now, this is survival in MADE-IT 2 trial. This had just over 1,200 patients who had myocardial infarction more than 30 days prior to enrolment, and more than 3 months if bypass surgery was performed, and ejection fraction less than 30%. Patients were randomly assigned to either prophylactic defibrillator or conventional medical therapy. The study was prematurely terminated after an average follow-up of 20 months because the ICD group had a significantly reduced all-cause mortality. It was 14% versus 20%. The survival benefit was largely due to a reduction in sudden death. So the ICD was implanted, but she deteriorated 9 months later and was noted again to be in NYJ Class 3 category with shortness of breath and reduced exercise tolerance. She was compliant with her current medication. Both her heart rate and blood pressure were controlled, and the ECG demonstrated sinus rhythm. The echo, however, still confirmed poor left ventricular function. Looking at her next steps in the algorithm, you can consider any of the following treatments in isolation or together. So there's no indication for either upgrade or to CRT-D, although this would have been considered if her QRS had become broad, particularly if she had left bundle branch block, or if she were to be significantly RV pacing from the ICD. Ivabradine could have been considered in addition to beta blocker therapy if her heart rate remained above 70, but you can see that it's well controlled at 60 beats per minute. However, in this case, we added in sacubitril valsartan, Entresto, at the lowest dose and stopped the ramipril. We also made an assessment of her comorbidities. So the 2016 European Society of Cardiology Heart Failure Guidelines recommended sacubitril valsartan and ARNI. In this case, it's, initially it was called LCZ 696, in place of ACE inhibitor therapy for ambulatory patients with heart failure and reduced ejection fraction who remain symptomatic despite optimal treatment with an ACE inhibitor, beta blocker and MRA. Paradigm HF was a landmark trial that I'm sure you're aware of that was published a few years ago, which randomized just over 8,000 patients with heart failure with reduced ejection fraction. They had ejection fraction less than 40%, although some also had less than 35%. These were used at different time points in the trial. And NYJ class 2 to 4 symptoms, either to sacubitril valsartan or enalapril 10 milligrams twice daily. That was the goal dose used in the landmark consensus and solved trials. There was a median follow-up of 27 months, and the trial again was stopped early following a positive interval efficacy analysis. There was a 16% reduction in the primary outcome of cardiovascular mortality or heart failure hospitalization, 22% versus 27% in placebo group. There's also a significant reduction in all-cause mortality, 17% versus 20% in the placebo group. So there appeared to be a slight improvement in her symptoms, and she moved into class 2-3 NYJ category. The sacubitril valsartan was gradually increased in 1 monthly intervals, and there was a slight drop in her blood pressure, although she was not symptomatic. Renal function and potassium levels were stable. After about 3 months, she was in NYJ class 2 category. Now moving on, the last part of the talk, I think it's very important, this particular section of the new ESC heart failure guidelines, it's the comorbidity review. We often focus on just the heart as cardiologists, whereas in fact there may very well be other disease processes which need to be identified and treated and can help symptoms. Older patients in particular require a more complex, holistic evaluation and have a worse short-term prognosis across a spectrum of morbidity, cognitive and functional decline, and risk of institutionalization and mortality. So in the ESC heart failure pilot survey, about 3/4 of heart failure patients had at least one comorbidity, and commonly these included renal disease, pulmonary disease, iron deficiency or anemia or a mixture of both, and diabetes mellitus. However, you look closely, a significant number of patients have more than 5 comorbidities. We made a full assessment of the comorbidities in this lady. I have to be honest, in hindsight, we should probably have assessed these at an earlier stage. And although she was not anemic, she was found to be iron deficient with a low transferrin saturation and a low ferritin level. Based on FAIR-HF and the CONFIRM-HF data and the Class 2A level of evidence A from the ESC guidelines, she was given intravenous iron, ferric carboxy maltose. It must be noted that oral iron is not appropriate in this context as it's poorly absorbed and poorly tolerated. Amazingly, she was in NYJ Class 1 to 2 category only a week later. She was also referred to the sleep clinic as she had symptoms of obstructive sleep apnea, and subsequently actually was started on overnight CPAP therapy and also referred to a weight loss program. So, in conclusion, the ESC heart failure algorithm is, I think, a very useful guide to follow, starting with ACE inhibitor and beta blocker therapy and spironolactone or a pleura if still symptomatic, so triple therapy. There are further options which should be explored in parallel for all our patients. In those who have severe LV impairment despite optimal medical therapy, an assessment of sudden cardiac death must be made in consideration of an ICD. Lastly, there are many comorbidities in patients with heart failure, and a comprehensive assessment should be made early on and reversible causes treated. Thank you very much.